So good morning once again, everybody. This is Jermaine Alberty with Live and Well Communities, the interim director, and welcome to our learning community session for January. Our topic today is responding to trauma to create equity in healthcare. And so we have three wonderful speakers that have joined us today for this conversation. Right now, you all are completing a poll that has two questions. Those two questions are, have you felt unsafe when encountering a healthcare professional? And what are some of the obstacles that you've encountered in achieving good health? So we're giving you a moment to answer those two poll questions. And then we'll look at what the results tells us. So right now we're doing really good. We have 26 of 30 of you all who have engaged the poll. I'll give you a couple more minutes to answer the questions. I know some of you all just came into the call.
What the hell? Oh, come on, Susan.
I would ask everyone to mute themselves if they are not asking a question or not presenting. In about 15 more seconds. All right, I'm going to end our poll and I'm going to share the results. So as you all can see, in regards to our first question, a majority of you all said no. 61% said you do, that you have not felt unsafe when encountering a healthcare professional. So majority of you all feel safe when encountering a healthcare professional. Of course, we do have about 0.9% of persons who said yes, they did feel unsafe when encountering a healthcare professional. With regards to obstacles to encountering and achieving good health, it looks like a majority of folks have landed on the affordability of care has been an obstacle in achieving good health. And then the second runner up is actually access to care, along with tied cultural competence of providers as well as previous traumatic experience. And so what we know is that when we talk about equity in health, that there are many things that keep individuals from achieving that good health. And we know trauma is one of those things that also keeps people from achieving good health. So we have invited to join us with us three speakers who are going to talk about equity, talk about trauma, so forth. As you can see here, our objective here is clear, that we hope that we will be able to learn about how we're working to advance equity-centered trauma-informed care in healthcare settings. And our panelists today are going to share with you how trauma-informed work is specifically addressing the harms of racism and other forms of oppression that lead to workforce burnout and health disparities. What we know is that trauma and its associated long-term negative consequences is a severe public health crisis. And those things contribute to that persistent, inequitable, and unjust healthcare outcomes. This morning, we have three leaders who are doing good work in this area. Our own Kristen Simpson is a director of healthcare activation with Alive and Well Communities. When we sent out our invite, we sent to you these nice bios of what these individuals did. And I'm going to have them, when they speak, share with you what else they would like for you to know about themselves. Our second speaker is a board member of Alive and Well, also, as well as a program manager of trauma-informed care with Kansas City, and that's Patty Davis. And then our last presenter is a partner and a friend of Alive and Well, Alison Williams, who is the Vice President of Clinical Quality Improvement at Missouri Hospital Association. So we're going to have our speakers go in this order, beginning with Christian, then we will hear from Patty, and then we will hear from Alison. So Christian, I'm going to give the floor to you.
Thank you so much, Jermaine. Good morning, everyone. I hope that you're staying warm and safe. And I'm so excited to be here today. So thank you for allowing me to speak at this opportunity, or inviting me to speak at this opportunity. And really just excited to talk about the innovative ways that we're trying to get healthcare spaces to recognize the long-term effects of trauma and the ways we can improve health equity for everyone. So we can go ahead to the first slide. So this is just a quick overview of what I'm going to touch on. Currently, I am in the middle or close to the end of a 2 and some change year pilot with the Missouri Hospital Association, talking about equity-centered trauma-informed care and what that looks like to implement that into hospital systems. But it really goes beyond that. When we think about healthcare, we don't just think about provider, patient, we think about people. So really, we're talking about a healthcare community. And the community takes all of us, right? From the people that are being served to those of us that are doing the serving. So this conversation is about everyone here. So we'll talk about first what equity-centered trauma-informed healthcare means. You'll hear me refer that to that as ECTIC. We'll talk about the transformational elements to implement this work into healthcare systems, what our focus is, which is what we like to call the quadruple aim breakdown, and how we've been able to transform and integrate this into healthcare systems from the bottom up. Thank you, Jermaine. So what is equity-centered trauma-informed healthcare? This is basically a new practice of care delivery that really addresses the consequences of trauma, understanding that trauma is likely to be the root cause of a lot of different fabrics of oppression that we see today. So by understanding how trauma affects someone over the course of lifespan, finding multiple pathways to recovery, and then us understanding when we know that trauma exists and impacts people in such a way, we can then start to practice how not to re-traumatize people when they come into our space. So in that, this model incorporates the added measure of identifying and addressing the experience, impact of healthcare access and outcomes that are diminished or withheld on the basis of individual or community characteristics. For so long, the way, at least I can say that I'm guilty of it, the way that we delivered healthcare was that, hey, we'll treat everybody the same, when really we need to have individualized interactions because everybody's needs isn't equal. And when you think about equality versus equity, that's the point that we're getting to, is that we'll meet the people at their need, which could be different depending on who you're encountering with. Next slide, please. So really the crucial, most critical part of the work that we do, and one of my most precious and passionate part about this work, is that we don't really make any moves or discussions or changes without having patient wisdom, as well as frontline staff wisdom, but particularly patient wisdom when we're talking about patient-centered policies and practices. So often we have teams and committees that are coming up with these policies and what training we need and, oh, how should we address this? It's the system that's making that decision, but we don't include the people that are affected by that decision. And so it's really twofold. You know, there's executive leaders that make the decision that could impact frontline staff or other support staff in the hospital that engage with anyone that comes into that system. And then you have the patients that are on the receiving end of that service. And so it's so important when you talk about community to bring everybody together to have these discussions so that we are sure that our changes are transformative and inclusive of everyone that's being impacted by those choices. So the way that we see this work evolving and manifesting in hospital spaces is you have to do workforce cultivation, as well as reflect on clinical practices. What does the organization look like a whole? What is the tolerance of allowing trauma to continue to not be addressed and us not, continuing to do professional development in that regard? And then do our policies reflect the way that we want to practice? So the most important part is this quadruple aim discussion. And really, I would argue that where you see care team well-being as number 4, it really should be number 1. As a clinician myself, if I am not well, I am less likely to give and provide excellent care to those that I'm serving. I am also more likely to not have good interactions with those that I work with. We all have our own personal experiences that happen in our everyday life that we cannot plan those sort of events, and thus need space and opportunity to have quote unquote mental health days to process. We onboard a lot of vicarious trauma. So if you don't think that, oh, I've never been traumatized, well, at some point I'd love to have that conversation with each of you so that we can learn the different types of traumas that do impact us. And as a healthcare professional, or even just as a member of the community, the stories that we hear that causes us to react emotionally are labeled as vicarious trauma. And so when you're talking about the care team well-being, you're taking in the stories and experiences of everyone that you serve and those that you work beside, including the things that happen within your system. And oftentimes in healthcare, time is of the essence, and we don't have the time to process or take mental health breaks without feeling guilty about I'm leaving my team with less staff because I need a day for me, right? So how do we build systems that are also equitable to those that are doing the serving? Because we know that if we give you that space as a system, you're more likely to show up to work whole and able to provide as best care as you can to those that are receiving the service from us. And so we know if we have positive interactions with our patients, right there, we're engaging with them. I'm well, I'm able to listen completely to your concerns. I'm not being short with you. I'm not dismissing you. We're building trust with our community. And when we build that trust, patients come back because they feel like you really are addressing their concerns and need and that they essentially matter. So when they return, because they feel respected, they feel trusted, they feel embraced and welcome, we see a difference in population health because I'm keeping up with my primary, excuse me, I'm keeping up with my other specialty consultants as it relates to my health because I trust those that are in position to be the expert GPS guide to my healthcare journey. And so when I'm keeping up with my health, I'm engaged with my health, the providers I have a great relationship with them. You'll see cost reductions because then now we'll be able to screen for diagnosis early on instead of finding diagnosis kind of later when treatment should have been implemented. So there's just that quadruple aim. It really is a domino effect. And by us addressing our own needs first, right? It's kind of like the oxygen mask when you're on the airplane. They always tell you to put your mask on first before then you can help others. Well, this is kind of the same. We have to take care of ourselves first before we can serve others. And when we can build systems that do that, we will see a positive outcome in our healthcare community. So the way that we envisioned implementing this in healthcare spaces right now, as I said before, the hospital system is what we're working with right now. We first just do mass education of just getting the understanding of what trauma means and making that language consistent across departments or across the system. Once people have a general understanding of what trauma-informed care means, then we start understanding what it feels like to be trauma sensitive. So creating teams that really want to push forward this work within their system to be able to identify some ways where we can enact and launch new changes and be innovative about the way that we practice healthcare with our community. Most time what I've seen is people like, oh, we can't do that. And it's not a can't, it's that we've never tried or we've never asked. So oftentimes there's these groups, what we call our champion teams, that are inclusive of any position from the front desk staff, the EVS staff, so that's environmental safety, your nutrition person to the CEO at the top of the organization that are included in these discussions and making sure that we're creating spaces for transformative experiences with our staff and those that we serve. So once we get to trauma sensitive, we think about trauma responsive. So trauma responsive, say that 3 times fast, maybe you all can. And so when we're being trauma responsive, we recognize that I'm aware of trauma. I become sensitive to it because now I can see it, within myself, my family members, the people that I serve, my colleagues. So now I need to practice different ways of responding to trauma when I'm engaging with professionals or with the community that we serve. And then becoming trauma informed. How do we embed that into our systems, changing policy and workflow, and then continuing to expand that across the organization and seeing what other needs after doing an assessment that needs to take place to really push that to the next level. So in reflection, I know I've said a lot. What we have found is that a lot of our healthcare partners have had some fantastic experiences with this pilot that we've been working on, specifically so that patients have noticed a difference. We are hoping that we're de-escalating the need to call security for situations where people are just in a traumatic state and they're operating outside of their window of tolerance. And so how do we know and recognize when we see that, like, hey, you're not really upset with me. You're upset with something that's happening or something that could be happening and been happening that I have no clue about. You don't owe to tell me what that is, but because I understand what trauma is, I can come to you with grace and give you space and make you feel safe. And let's work together to find this resolution of how we can build equitable spaces and hear your needs. I think too often, and I will say just within my own training, we think about this as, hey, I'm the provider, you're the patient, you have to listen to me, I'm in charge. When really, we can't even serve them without them. Anybody that comes to our system, it requires them to tell us their story. So how do we spend more time investing in their story and their testimony, and then being their advocate of their life experience, because they're the expert of their own health. And we're just the guide to say, hey, here are my recommendations on how you can improve your health and continue to maintain that health. And not, I am the power force that tells you what you need to do, but how do I partner with you to help you see the ways that you can maintain your health overall? So that's ultimately what I have. Thank you so much, Jermaine.
Thank you, Kristen, for sharing. We are going to have a Q&A period, everybody. So just know that if you have questions for Kristen or Patty or Allison, we're going to set aside some time for that. With that being said, I want to invite Patty Davis to share her presentation. So I'm gonna get your PowerPoint moving right there. And Patty, just tell me when to advance your slide and I'll do just that.
Thank you, Jermaine. Hello, everyone. I am Patty Davis, and it's neat to see so many friends and respected colleagues as you guys were popping in. So I'm in the Kansas City area. I'm at Children's Mercy Hospital. I'm a clinical social worker here, and my job is as a program manager for trauma-informed care, trying to move our hospital into something that we can say, yes, that was a trauma-informed experience that my child had at that hospital. So working toward becoming a trauma-informed organization. I've been here for 20 years and have seen a lot of changes and are currently seeing a ton of amazing changes. And I wanted to share with you how we've gone about that process. So Jermaine, you can move to the next one. So in general, I just want to remind folks, this is part of the education of the why. When I talk to staff members about why are we talking about this? Well, trauma in and of itself has so many things that can cause a traumatic response by a person that's come into the system. And there's really quite a lot, but I wanted to give some high level ones that we don't always think about, but I think are also relevant to discrimination and inequities and bias, even unconscious bias. A person, whether it's the patient or their parent, can feel unheard by that provider or that team. So I know our first question was about, have you ever felt safe with a healthcare provider? Sometimes it's maybe not as unsafe as, I don't know that they really heard what I was trying to say. They were talking over me. They were moving past it. And that's one piece that we need to keep in mind, is we don't have everyone's full story. So we need to really be listening to get all the information in order to help them medically. Also, persons experience traumatic stress when they're feeling inadequate as a parent. And so this is really, should say, how trauma can manifest in pediatric health. It's not all healthcare, but in pediatric health, it's a big thing to come in with your child and wonder, did I do everything I was supposed to do for my child? Because if not, I'm afraid they're going to let me know and it's not going to feel good. And nobody wants that feeling. But it can become a norm, especially if our providers and nurses are incredibly busy and they're saying, oh, why didn't you do this? Why didn't you do that? And that in and of itself can cause me to not want to go back because what am I doing as a parent? There's family blame. Some parents come in and they've got people around them that are saying to them, their family members, what are you doing? And so they come here and they need to have some support in that. There's a power imbalance when facing experts for many. So just in general, a lot of folks have had experts talking to them their entire life and or their community and not being engaged and not really hearing them and not really seeing them. And when that happens, they can experience that with the experts that are providers in a healthcare setting and not feeling comfortable just because this person is talking to me as if they have all the answers and I don't, and I haven't had a good experience with that. So that could be a triggering experience for someone. And then stress of being asked to find support in the family or community. That really happens a lot, especially in pediatrics, but I know it happens everywhere. I see it in pediatrics where we're asking parents, we need you to do all of these things. And they're staring at us thinking, I'm a single parent and I work 2 jobs. How am I going to get all of these things done? And this isn't my only child. And so we're sometimes assuming that they have the support in the community that we'd like them to have. And we need to think through how can we support them in finding those persons or how can we support them otherwise. And then having a lack of trust, that if we're not trusting the medical setting, then walking in the door, not sure if they're there to help us. So it's going to be hard to follow recommendations if we don't fully trust that provider. Jermaine, you can go to the next one. Thank you. So I do want to share a part of our education includes talking about racial bias. It's talking about how that is health inequity, that leads to health inequity, and that is in and of itself a trauma. So I'm just going to go through these 3 pieces of literature here. In 1999, the Institute of Medicine said the vast majority of published research indicates that minorities are less likely than whites to receive needed services, including clinically necessary procedures, even after correcting for access-related factors such as insurance status. So that's an astounding find, and I have to keep it up because it's still true today. So we're more than 20 years later, almost 25 years later, and that's still relevant. And so I share this with folks that we work with. You may be a wonderful person and a God-fearing person, whatever you believe helps you to be the best person possible, but you're part of a system that isn't treating everybody equally. And we have to remember that or we won't be able to change that. For pediatrics in particular, in 2009, they said the impact of discrimination on health outcomes of children of color is may be exacerbated by bias from healthcare providers. And that was a nice statement. It may be. It is. We have bias as human beings, and when it's unconscious and we're not paying attention, we're potentially causing health inequities. And then in 2019, pediatrics came out with a policy statement. Racism, not race, racism is a core social determinant of health that is a driver of health inequities. These health inequities are not the result of individual behavior or choices or genetic predisposition, but are caused by economic, political, and social conditions, including racism. So these are reminders that I share with our staff at the hospital that we're all a part of this system where health inequities exist. Therefore, we're a part of creating that. So we need to work really hard to find them and to mitigate and stop that from happening. You can go to, there you go. And so I love. I love this model. So you guys are here, we're talking about trauma-informed care. And so I'm sure many of you know about the Adverse Childhood Experiences study back in 1998 when it was published. But in general, I'll explain a little bit about that. I love this model. It was created by Wendy Ellis. She's a researcher at George Washington University. And she says she developed this one sitting at her table with her children and just talking about how do I really fully get the whole picture of trauma? Because is trauma these individual adverse childhood experiences, so physical and emotional neglect, maternal depression, substance use, domestic violence. These are all things that this study, the ACE study back 25 years ago, helped us to understand that negatively affects long-term health outcomes. These things that happen to a person prior to the age of 18, not things that they caused and did themselves, things that happened to them that were negative. And in this tree model, you can see those are things that we do talk about. We probably didn't as much 25 years ago, but we do talk talk about that today. We're reducing the stigma to help folks know it's okay to talk about these things that have happened so that we can help them and find healing. And we can see those things and they're part of the clinical work. But what's interesting and what's important to think about is not everybody comes in with the same ability to move and push past that. And so there's so many amazing resilience factors that are out there, but why are they there? Because not everyone's tree has the same water in their root system. Not everyone's tree has the same ability to keep it growing strong. And there's things within those communities that can cause disruption and can cause problems that then negatively affect a person that's trying to deal with the abuse and neglect that they've already experienced. So those include poverty, discrimination, community disruption, lack of opportunity and economic mobility, poor housing and quality and affordability of that, and violence in general. So I love this picture. I hope you guys love this picture and can look up her work to look at more of that. But it's about helping our staff members at Children's Mercy recognize, which was kind of new for them, to really think about these adverse childhood experiences 5 years ago. And we're trying to say, well, but let's even consider the deeper thing. What's in the water? What's in their environment? So how else can we look at what's negatively affecting that child's growth and development, and how can we support beyond that? Thank you. So our model at Children's Mercy is looking at 3 different prongs that we can't let it all go. And I don't want to bog down. I love the quadruple aim, and we've got our 3, but really we needed to simplify it for ourselves, just to think about how do we organize a trauma-informed program for our hospital. And so our simplification was, well, we have to first let staff understand. They need to know the science of traumatic stress, and the science of traumatic stress can help us understand the effects that trauma, things that happen to us, can have on our individual self, can have on our families, can have on our communities. And so really that's the why. So this awareness piece is, we have a goal for everyone in our hospital to be fully understanding and fully aware of trauma-informed sciences. And we've made it pretty far. A lot of folks have had just that basic stuff about the science. We have a ton of education that we can offer, but we work really hard to get everyone under that understanding. And that's where they can see those aha moments. So, wow, I didn't recognize that. I didn't understand that. Now my patients' reactions make so much more sense to me. So we love those aha moments, and we really want all of our staff to keep having them. And so that's the why, and that's the awareness piece. But once our staff have done that, then they say, well, what do I do next? Okay, I get this now, but how do I make changes? And so sensitive practices are things that we look as, how do we have universal precautions? We're not going to know every patient history or their parents' history or their siblings' history, that all might be relevant in how they're engaging and encountering this healthcare experience. So let's have some universal precautions of how we'll treat patients and families when they walk in the door. How can we assume that some of these things have happened? And so we talk and we ask questions and we see if things are okay. And so we'll talk a little bit about how we get to those sensitive practices, but mainly we're looking at everything under the lens of the key principles of trauma-informed care. And then our foundation of this model, well, that's okay. Thank you. Our foundation of this model is resilience at work. We cannot forget that as human beings, we're affected by traumatic stress, including witnessing and seeing every day really tough things with patients that are ill, patients that are dying, patients that were severely maltreated. And this is part of our everyday for many that are in the pediatric world. And we can't share that with others necessarily at the kitchen table when we go home for dinner. So we have to recognize that could be happening. And just as Kristen said earlier, we need to think about how do we take care of ourselves and recognize that that's a traumatic experience that could affect us, so that it doesn't end up changing how we approach services and how we do our job. In addition, we all also have our own tendencies for our own histories where we may have had traumatic experiences that are then being triggered by the patients and families that we see. So we keep in mind this resilience at work piece as 1/3 of the model for becoming trauma informed. Thanks, Jermaine. So this is those trauma-informed key principles that I talked about. I'm sure a lot of you have seen these and know very much about them, but I'm going to go over them very briefly. We really want to think about, when we're thinking about how do we change our practice, we want to think about how do we incorporate safety, emotional safety. Not everybody who walks into a room is feeling safe in that room. So what can we do to help them? We know to help them feel safe, to feel supported, to feel that we really care about what they have to say. They're there and we're here to support. Not not just their child. We're here to support that family because that's where that child lives, is within that family system. We want to increase trust. And so we know in order to fight healthcare disparities, or I should say this, the vast majority of literature out there talking about health inequities talks about 10 to 15 major issues in that. Well, I'm not going to come to work every day and fight all 10 to 15 of those major barriers and why we have health inequities. But one of them is a lack of trust from the patient to the providers. I can work on that. I can build trust. That is one thing that I can do individually to help patients feel more comfortable. The other thing is health worker bias. And so I'll talk about that in a little bit too. But the next thing there is choice, choice and then collaboration. How do we give them every opportunity to be a part of the solutions here? When we provide evidence-based understanding of this is what you should do next medically, we need to hear from them. How do you see that working for you? How can we offer choices to them? A lot of persons that are in negative situations don't have choices to be there. So it's quite unique sometimes for them to even say, I've had patients come in and I say, hey, and I'm a mental health provider, by the way, I don't want to confuse that, but I'll say, hey, you guys, they say, where do I sit? I said, you could sit anywhere. And they look at me like, wow, this is a whole new place. They're not used to having such the ability to make even those little choices. All the times that we can give choices are all ways to help a person become and feel more safe. Empowerment is so important to have that person have a seat at the table, but also to share those skills. So in pediatrics, we talk a lot about we don't want it. Children's Mercy, we do not want to be heroes for children in bad situations. We absolutely don't. We want those children to get better, but we want their parents or their guardians or whoever can care for them to become their heroes. So we want to empower those parents, empower those guardians to have the skill sets to help that healing process take place. I'm happy to be on the back end and say, yes, I'm helping to teach you to do that, but I want you to be the hero for your child, because hopefully in 6 months or a year, as far as my work goes, I won't be seeing that child anymore. They're going to be seeing their parent and their guardians. And so they're the ones that I want to empower with the skill sets. And all of these principles need to have a foundation of cultural humility. So Alive and Well has equity in the center. Cultural humility is about equity. Cultural humility, however, has a different background. It was developed by two pediatricians at the end of the 1990s, and they looked at how do we increase equity or reduce health inequities, specifically racial health inequities in pediatrics. And that's when they developed this 3-point model of cultural humility. But I do love it. One of the things they talk about is, yes, everybody in the academic world has talked about cultural competence, but when are you ever fully competent in someone else's culture or someone else's world? We're never fully there. So cultural humility is really just even changing that name helps us to recognize when every time we have a handshake, it's a cultural exchange. I don't know someone else's history, whether they look like me or look different than me. I don't know it, no matter how much I study it. I really need to be humble and understand that I need to hear from that person and from that parent. So we don't know what we don't know. And so we need to connect together. So those pieces are part of the cultural humility. And you can click one more time, Jermaine. One of the ways we do this is through some intense education. We have a ton of our Office of Equity and Diversity has a ton of education that's out there for understanding unconscious bias. And it's really important for those individual personal changes. I am a white, cisgender, heterosexual Christian woman. I am a person that a lot of the oppression has never been affected toward me, hasn't been geared toward me. I mean, I suppose the female part of me is the one area that it is, but in general, I'm part of what's considered the dominant part of society. I need to hear more about cultural humility, and I need to learn about my own biases more than anyone else that's out there, or as much as anyone else that's out there. So we do a lot of work of individual aha moments and changes with our patients, with our staff. And one of them is our work toward cultural humility, and we work through that piece as well. So you can click to the next one. So knowing that, having those individual changes is fantastic and wonderful, and we're working really hard to do that. But it's also important to think about systemic change. Oppression comes systemically. There's systemic oppression. There's systemic situations where we have patterns or the work so that everybody is a part of it. So if my neighbor never had the training and never had those aha moments that I'm working with, they'll still be a part of following this system of care that is trauma informed. And so one of the ways, one of the tools that we use is something called a Thrive Guide. And we work with parents when they are admitted and at other times. And when we hear their stories and we hear things of, I've been here before, I was not treated well, or I've been here before, you guys don't understand my child's needs. Every time I come in, I have to re-explain it. Or I was here a year ago after the death of my child, and this is horrific coming back here today with my other child who has the same medical condition. There's pieces of family stories that they want us to know, and they don't want to have to repeat it every time. And so one thing that's been developed a few years ago at our hospital, and we're still trying to push it and disseminate it hospital-wide because anything systemic like that takes a while, but it's called the Thrive Guide. And we work with parents to say, hey, what can we know about you and your family that would be helpful? How do you prefer communication? Sometimes they'll say, you can say everything to me, but I cannot talk to him, maybe the child's father. So I need you to also repeat it for him. Well, that's good information for us to know. Otherwise, when we're talking to the dad, we may not realize he doesn't have the same background information. So we want to know about their communication preferences. We want to know about any stressful events that they want us to know about. We don't force anything on this. And we want to know about how do they cope? What could be helpful for us to know? And we don't demand any of this information. We just say, if there's information that's unique for you to your family, please let us know. And we'll put it on this form that everyone can read, that folks can go in and have a short, succinct piece of information about this family. Boy, if I'd known that, I would have approached them a little bit differently. So that's the kind of information we're looking for to have on this Thrive Guide, because there's no way our providers and nurses are going to be able to read every psychosocial note with that history. So this is an example of how to get at some of those things right away to increase that sense of safety. And so one of the things that I wanted to share is we've been working on DEI, and we've had an Office of Equity and Diversity for some time at Children's Mercy. We've really kicked it into gear in the last few years. And we have a Chief Equity Officer. We have a new Children's Mercy DEI strategic plan that's for 2022 to 2025. And I'm so excited about it because trauma-informed care is a part of it. So we recognize we cannot look at fighting inequities without understanding the effects of trauma. And we cannot work on understanding the effects of trauma without recognizing that without doing that, we're causing inequities. So in general, I wanted to share with you the 4 overarching goals. There's the health of our patients and families that we think about with the community. And really with that, we need to expand our ability to gather data, and not just data on how our patients are doing, but how our patients are doing in comparison to their characteristics, maybe their race, ethnicity, where they live, their socioeconomic status, their language that they prefer. We need to understand all of the pieces that are relevant to how can we make sure that we're not missing any pieces. Why does this group seem to be doing better than that group? Well, I don't know. We need to focus on this group over here and figure out some solutions. And we cannot do that unless we have clean and clear data. And so we're working through that quite a bit now. The other thing that we want to do with that is we want to hold individuals and their departments accountable. So we want to have directions for what are they coming up with, what is their plan, what is their annual goal, whether it's their personal annual goal for their own work with their manager or director, or whether it's the goals of their department. We want to look at the health of our mission and our culture in the workplace. So this is one that I'm most excited about, because this is one where we really want to think about how do we include diversity, equity, inclusion, and in trauma-informed care into every structure and every strategy, every policy, every procedure, all the practices. So the practices are those individual things, but how do we look at the policies? Let me look at that policy of the no-show policy. Are we really including full transparency, safety, choice, collaboration, empowerment, cultural humility when we're thinking about this policy, or do we need to revamp it a little bit to include all of those principles? So that's a piece that we do quite a bit in our hospital. And then the other piece is looking at our workforce. We also have inequities in our workforce because, you know what, we're an organization of 8,000 plus. And so we have not figured out that piece either. So in addition to needing a lot more diversity and inclusion in our workforce to help our patients and families, we also need it just to be fair fair and equitable among our employees. And we do have employees that face discrimination, and we need to work through that. So that's a huge part. That's one of the 4 goals of the strategic plan as well. And then looking at our suppliers or vendors in the marketplace, I would say marketplace has a big listing of things under it. But the first thing is we had already been working on looking at our suppliers and vendors. And are we working with local folks? Are we working from folks from populations that are at risk for health inequities? And if not, we need to get there. And so those are the pieces that we're working on right now. So that's my presentation. I can answer questions later.
Patty, thank you so much. Allison, I want to pass the time to you.
Yes. Hi, everyone. Can you hear me okay?
We can.
Okay, perfect. So thank you for the opportunity to be on this presentation. Kristen and Patty have done a fabulous job of outlining a lot of the tenets around this work and some of the amazing efforts that are already ongoing. Just to give a little background, so I am from the Missouri Hospital Association. For those kind of unaware of what the Hospital Association is. So we are a member-based association that represents the interest of the hospital industry in the state of Missouri. So we have 140, all of the hospitals in Missouri are members of MHA. But along with representing the interest, our board definitely has a directive to us as staff to encourage and drive them in new and innovative directions and into doing different care modalities and care delivery models and opportunities to improve their care that helps to improve healthcare outcomes for across the state of Missouri. So that is where a lot of our efforts in this space have been driven from, is a definite board level engagement around the idea that equity-centered trauma-informed care is a definite healthcare priority. Next slide, please. As part of this effort, Kristen alluded to when she first talked about the presentation, we have been engaged in a little bit more than 2 years. COVID had some impacts there on our ability to proceed at times, but we have been engaged with 3 different hospital systems and clinics across the state and in supporting a pilot effort to implement the ECTIC model, especially the awareness elements of that model. Into several organizations, specifically in their emergency department and in their maternal infant care settings. And so that has been an amazing experience. And we're really excited to finish up some of the evaluation in the coming months with our Alive and Well partners and to really get into the learnings of that pilot and then look to spread and scale those efforts. And then the picture here on this slide is of our health equity initial document and guidance resource for members. And it really is a lot of just explaining some basics around health equity, around trauma-informed care, some basic definitions, and trying to start some more significant outreach efforts to spread and scale this information throughout the healthcare sector. The diagram there on the left is really around our department within MHA. One of our key focuses is improving population health really across the lifespan and across multiple populations, especially those who are experiencing disparate health outcomes. And we are engaged in this work with our members in a multitude of ways that we'd like to make sure that you're aware of. Many of you I know participate likely in community health needs assessments that hospitals are required to do every 3 years as part of their IRS process. Initially, several years ago, I think these were kind of a token effort, but I would definitely say in the last 5 years, the CHNA effort has really grown some serious legs, and we're flexing the muscles there a lot more on the hospital side. So we're seeing a lot more engagement. Patty just alluded to vendor and marketplace engagement, and we're seeing that for some of our really innovative systems and hospitals throughout the state. They're really starting to take off in those spaces and to think through a lot of the DEIB factors there, utilizing data, the information they're collecting from their communities to really drive how they're going to be able to meet those needs, the social determinants of health factors, and looking at the gaps in equity that they have. Along with that, as been mentioned, I think Kristen and Patty have done just a tremendous job today of outlining how does trauma and understanding experience personal trauma fit into the health equity discussion. And to us, it's a very clear-cut line. And so it's something that we plan to continue to engage our members in and spread and scale throughout the next few years as part of our strategic goals. And then moving towards that is how can we help them develop some competency and to look through utilizing proven tools, looking at those policies and procedures, and how can we really work to reduce disparities. Next slide, Jermaine. So this is the definition of health equity that we're utilizing through MHA, and it really is espousing to our members. It's from the Robert Wood Johnson Foundation. And the big piece that we try to pull out of this, because we do serve a very wide variety of organizations, from, you know, urban core metro hospitals to pediatric children's hospitals, all the way to the smallest critical access hospitals and the smallest rural towns across the state. And so what we've been trying to focus a lot of our members on is really this idea of obstacles equaling disparities. So when people face any obstacle, whether that be because of the circumstances they live in. I love Patty's analogy to the water, and, you know, and what's in the water there. I think that's so beautiful. But whether they're living with poverty, whether they face chronic generational discrimination, whether they have a lack of access to a myriad of things, those things create obstacles. And so part of our work in this space, and as providers, is to seek to understand what those obstacles are. And while we may not always be able to remove them, again, I think, as Patty so beautifully illustrated in her discussion today, seeking to at least have a knowledge and awareness of them and how that might impact the patient's ability to achieve their health desires. Next slide. So along with, you know, our own desire to want to do this work, in the this last fiscal year, 2023, Centers for Medicaid and Medicare, and Medicaid Services released their inpatient prospective payment system rule. And so these rules really guide, especially acute care organizations. It guides a lot of their regulatory requirements around how they provide care. And so this is my little stick and carrot analogy. So we have a lot of organizations in the state who are on leading efforts, and they have the carrot in front of them, and they're being led by that carrot to improve health and to work within their communities to do so. And CMS has now come out and said, okay, we're starting to implement the stick now. So I want to just make you aware of some of that. And this is a lot of the information that our members are getting actively throughout the last few months, and we'll continue to push this moving forward. Next slide. So this is CMS's framework around health equity, which includes, again, trauma-informed care practices and understanding the circumstances that people are you know, literally living within and working within, and how that impacts their ability to achieve health. So the first priority is really around standardizing data collection practices, which is actually quite disparate and leads to, you know, the inability to identify opportunities to resource and work in a more efficient way, and to serve those who have needs in a more efficient manner. The second is to assess the causes of disparities within CMS programs themselves. So this does include payment policies and, you know, ability to access care and things like that, and thinking about how we can help close those gaps. The third priority is building capacity of the healthcare organizations and the workforce to reduce health and healthcare disparities. The fourth centers around, I think, back to that cultural congruence, cultural humility aspect that Patty spoke of. One of the biggest things that we see here, whether you live in urban or rural areas, it doesn't matter, but there are a lot of health literacy, but also language disparity factors that really inhibit and create disparate health outcomes. And then really accessibility issues around healthcare services and coverage. Next slide. So again, I mentioned this is the rule, and I can send that out if those of you who would like to look at that. It is a very long rule, but it does cover, in order to get their Medicare, Medicaid payments, hospitals must meet these milestones that I'll go over in another slide. And so this is important. So this is the stick, right? This is, we don't pay you unless you complete some of these rules, and this is how CMS moves some things forward. So The rule does finalize new measures that hospitals must report on that help to build really a foundational level of health equity into core functions all the way from the bedside to the boardroom. And we're very excited about this opportunity and have some resources I'll talk about in a moment that we're providing to members as well to help them with these, to be able to meet these measures. And again, the whole goal is to improve the care that we're providing, especially to those who are disadvantaged or marginalized within the healthcare system. Next slide. So this talks about the three goals, the three measures, excuse me, and the identifying goal. So what hospitals have to do over this year is to basically attest yes or no that they are screening patients for patient level health related social needs. So what are commonly referred to as social determinants of health. That's the second measure. The first is a commitment of culture and equity. And I have that on the next slide. We'll talk about what those are. In the coming years, the third measure is that they are to report what is the screen positive rate for at least one of the SDOH factors. There are 5 that are being reported to CMS. So the hospital has to put the framework in place. Then they have to make sure that they're assessing patients 18 and older, all inpatients for SDOH. And then, and are they doing that, yes or no? The third measure then is, again, what are your outcomes? So what kind of things are you finding when you're screening patients, and willingness to report that? And so in the future, these will be advanced, we believe, to not only be reporting yes or no, we're doing it or we're not doing it, but actually reporting the outcomes and then being held accountable to quality improvement activities to then close some of those gaps and reduce the disparities. Next slide. So this is really the infrastructure, I would say, that hospitals are expected to, hospitals that are inpatient prospective payment system reporting hospitals, which are most of your larger acute and rural hospitals. They must attest to all of these domains, including being able to meet every dot point that is listed out here. For the sake of time, I'm not going to read this to you, but you can see that there really is a lens towards board level engagement, so high level leadership engagement, which ideally includes your communities members as part of your board, data collection and analysis, and then quality improvement and leadership engagement activities to then improve any of those negative outcomes that are seen. Next slide. Oh, this didn't come through very well. Go ahead and click through a couple of times, Jim. So this is a kind of a different value equation that we've been looking at doing. It's missing the workforce there, but we've looked at value as quality over cost of care. And in recent years, things like the patient experience and those survey results have been added to that. And then in more recent times, we've really started adding, okay, let's look at equity. And then, as was mentioned in a couple of the presentations, both presentations actually before me, about the health of the workforce. So especially with the pandemic impacts, the workforce in healthcare, as you, I'm sure, read about daily, is not exactly thriving today. So these are things that we need to work on, and understanding the trauma experience of healthcare workforce as well as understanding where our patients are coming from. And so I just kind of put in here, these are all areas where trauma-informed care fit into so well. So they fit into the experience, they fit into equity, and they definitely fit into the workforce. Next slide. So this is a few links to some of the MHA supported programming around health equity and trauma-informed care. We are initiated last fall our health equity guidance, as I mentioned. We also released last fall health equity dashboards, which are open to the public on our website. So you can look there, there's 5 different domains that you can look through and try to understand some of the social determinants and disparities factors and outcomes based on diagnoses, based on population segmentation. It's pretty robust. We are in the midst of releasing in the next month or so hospital-specific dashboards. So our members will be able to have their own set of dashboards to compare themselves across the state with like organizations on how they're doing across a multitude of categories broken down by health disparity factors. So really getting into supplying that data need that is really important to being able to target solutions. As Kristen again talked about, we're really excited to finish up our almost 3-year, it seems like, pilot initiative with our hospital and clinic sites across the state, and looking forward to sharing that evaluation, lessons learned, and how others can learn from this effort and be more intentional about implementing ECTIC practices, both, again, for the health of their patients and outcomes, but also for the health of their workforce. We've got a lot of work going on in the maternal infant health space, and I've listed some of those there. And then just for your reference, there are American Hospital Association and also the Joint Commission along with CMS has also come out. If the organization is accredited by Joint Commission, there are health equity and trauma-informed care aspects that must be met for that accreditation as well. So I guess in closing, what I would like to say is that healthcare organizations are standing at the ready to be partners, especially with a lot of the community members that we serve and community organizations that have been doing a lot of this work for quite a while. And so I would highly encourage you all to reach out to those organizations and just to know that we're ready to be at the table. So thank you for the time today, and I appreciate the opportunity to speak to you all and happy to answer any questions.
Let's thank both Kristen, Alison, and Patty for their wonderful presentations. As you can see, we could have had 3 different workshops, just a wealth of information. I like to always do my best to honor our commitment to time. So when we say, hey, we're going to be done in this amount of time, I like to honor that. We have been in the room for an hour and in 1 minute. And so what we've asked our guests to do is to put their contact information in the chat feed. And so also what we're going to ask you to do is we need to know how this went for you. So we're going to put in the chat feed a evaluation we would like for you, if you would please, to do for us, so you can share with us how this presentation went. So I just put in the chat feed a link to a Google form with the evaluation. You can please complete that. That would be amazing. We will also email this to you. And we would love for you to most definitely send your questions specifically to each presenter that you may have, and they will get back with you with responses. Anybody who wants to hang around can most definitely hang around, and if our guests have a few extra minutes, we'll be happy to answer questions. For those of you who have to leave, we most definitely want to honor your time. So thank you so much for being with us. Jennifer Brinkman, the president of Alive and Well Communities, is with us also. And so just wanted to acknowledge her, that she's with us. And so Jennifer, you can say hi to folks if you like to.
Well, good morning, everyone. Thank you for being with us on a snowy, cold day across the state. Glad everyone can make the time. And thank you again to our speakers for sharing all that good information. I hope everyone got a sense of the kind of the scale of the work that's happening across the state that wasn't happening a few years ago. So that's really exciting.
And in the chat feed, a question was asked about the recording, if it'll be available. The answer is yes, it will be available on Alive and Well's website. We'll have that probably there by Friday. So that will be available. We also would encourage you to go ahead and check out our work that we did in 2022. All those presentations are recorded there. So we will just quickly throw in the chat feed a link that you can use to access those presentations. So that is in the chat feed right now. That will be the same link that you would use to get this presentation that was done today. So feel free to check out that link for past presentations. Patty, Kristen, Alison, thank you so much for your time and commitment to the work that you're doing. And we will wrap up.
Thank you for the opportunity. And I agree with you. If anybody has questions now, feel free to ask them. At least I know I can stay on a few more minutes, but otherwise I like the idea of the emails and the phone calls too.
I also have a few minutes to hang around. So if you have any questions, happy to answer them.